It creates huge disparities, huge issues of access to care. It fuels things like pandemics, conflict, trust in institutions and government. Anita, right now, 78% of the world's doctors are only treating 16% of the world's population in the global north. That leaves 5.6 billion people to be cared for by only 22% of the world's doctors. Our mission is to create access to world-class healthcare anywhere in the globe without concern for your economic situation, whether you're in crisis, and to leverage telehealth to help us do that.
Hello, everyone. This is Dr. Anita Lwanga. I'm here with my friend, Dr. Kim Tranquada. She is CEO and founder of Healthcare Alliance for an Equitable World. She's an emergency medicine physician with over 25 years of experience. She's an accomplished leader. She's a trained leadership coach and is passionate about building a values-driven organization that embodies global diversity, equity, inclusion, and access. And just before we started the recording, we were talking about some of Dr. Kim's travels. She's been to Uganda, which is where my family is originally from. So I'm so excited to hear her stories, to hear about her experience, and to hear about what inspired her. But before we get started, I would like you to share a little bit more about yourself. Beyond all of these wonderful accomplishments, what are some of the things you enjoy doing in your spare time? What lights you up?
What lights me up? So I spend a lot of time trying to balance between lighting up and refuel. As a lifelong overachiever and emergency physician, I think I've been go for a lot of my life. And I learned I'm probably actually an introvert. And I do well when I have time to resettle, to spend time focusing, thinking about things. I really like to think about things and connect unrelated things into something new and coherent. I'm a bit of a creator there. I come alive in that space. And making time to spend time doing that, being with my kids. I have 3 daughters from 27 to 12 years old, and spending time with them, just talking with them, playing games, just knowing more about them and their life is what lights me up.
Yeah, that is awesome. Definitely spending with family and friends and just being on your own, especially I understand as a fellow introvert, I understand, especially as an ER doctor, I can imagine like at the end of the shift, I just need my alone time to refuel because being an ER doctor is very hectic and very busy. So tell us a little bit more about how you decided to become an ER doctor. This is definitely, how to put it, maybe not as easy for introverts. I can relate to that. We would have probably done well in pathology and radiology, but sometimes life takes us in different directions.
Yeah, I never know whether I decided or life helped me decide. I think of everything as it needed to happen, and that's the journey I went on. I was born in Guyana, so were my parents and my grandparents in South America, and we came to the Bronx when I was only 7 years old. To say it was a big change is an understatement. Big transformation, and my story is like a lot of immigrant story. You give up a lot and there's a lot of change that comes with that. We came with my father. My parents were divorced, and little did I know I would never see my mom again. And I was raised by my dad and with my 3 brothers. My oldest sister turned 18. She left the house pretty soon after we moved here. And becoming a doctor was not something anybody in my family had done. It was not something that anyone had given me permission to do. But I think I spent a lot of my life figuring out how to do things that I want to do that aren't expected and that aren't allowed or aren't the norm. I've done that over and over again. And I was good at school. I loved biology, and I loved everything science and math. And someone, maybe not even somebody close to me, I tend to read and be inspired by things, said, look, if life is a ladder, reach for the highest ladder, if the highest rung. If you don't make it there, you will have made it higher than if you only planned to reach for the next rung. And I said, okay, what in my little imagination is the highest things I could reach for? Came up with astronaut and doctor. But I liked people. I liked helping people and talking to people. And even then I knew that the silence and darkness of space maybe not what would be best for me. So I decided to pursue becoming a doctor, not knowing if I would ever make it. And I had to take big bets on myself. An 18-year-old kid living in a low income working class family deciding to borrow money more than she can imagine to put herself through college and medical school was a wild imagining. But even then, I was like, I can bet on myself more than I can bet on anybody else. And I decided to bet on myself. And I kept enjoying what I was learning all along and kept going. And here I am.
I love it. I think it's so in life to bet on yourself. And I think as children, we have that like faith. Somebody tells us this is this, you're like, okay. Or you think a thought, you're like, okay. We don't question things. So I love how you have that open mind and faith. And even now with what you're doing, we're going to talk more about it. We're dreaming of what seems impossible and still achieving it. So I really love that. And I can so relate to your story as well. The child of immigrant parents. I think we moved to Canada when I was about 6 years old. So I think as children, we're more resilient than our parents going through this whole culture shock. But I think no matter what age you are, maybe mine is less than 2, there is this component of culture shock that we go through and straddling multiple cultures, being the child of an immigrant or being an immigrant, where we're essentially like the first generation, even though we came when we were quite young. And I didn't really realize you're from Guyana. So I think guys in South American culture is like pretty similar to African culture. So I'm also excited to hear about your story on traveling to Africa and what your experience was like. So tell us a little bit more about what inspired you to create Healthcare Alliance for an Equitable World. How did you come upon that and how are things going?
During the beginning of COVID, 2020 and on, I was starting to become a leader. I was a deputy chief of emergency medicine at my VA hospital, and an opportunity came along. First of all, I knew I wanted more, and I made myself available to people and asked for opportunities for more. And an opportunity came along to do something new and innovative that they'd never done before, which is create what they were calling at that time a tele-urgent care program. I didn't want to do urgent care, but I preferred emergency medicine. But I said, hey, go listen, go see. What can this be? So I went to meetings and folks were discussing what was really going to be an emergency medicine physician frontline direct to patients from their home program. And I was enjoying the vision that they were creating over time. And then it came to time that they were like, look, these have been great meetings. We've been doing this for 6 months to a year. It's time to launch. We need a director. And every kind of went. I quietly waited in the background. I have to say, for anybody contemplating your leadership, most important thing you can do is listen quietly and learn. Learn what your stakeholders care about, learn what your stakeholders want, and learn. Don't try to interject right away. So I sat quietly, and at the end of the meeting, I was like, if you're interested, this is my experience. I would be willing to do this as a trial basis. I was like, I've never done this before. How could I be the leader? But then I knew I was reading about leadership and why women don't get leadership and how men will go when they have 60% of the credentials and women wait till they have all the credentials. And I was like, these are my credentials. I'd be willing to do this if you want to give me a shot. And they did. And it was terrifying and thrilling to do something I had never done before, that the organization I was working in had never done before, in a virtual environment, which was so new. How do you build a team in a virtual environment across 8 hospitals covering 3 states? And I was like, all right, I can do this. And so I know a lot of listening and a lot of building team and building culture as the foundation for something through early listening, early visioning, making sure you give people the destination before you bring them back and you start to work on the nuts and bolts. And that was an amazing experience. And then after I did it, and it was super successful, and we had seen over 30,000 patients and resolved 65% of their care within the medical system with just a phone call. The people that were most sick referred to the hospital, saving lives with things like heart attacks and strokes. I was like, I want to test if I can do this again. Is this a fluke or am I really a leader? So I put myself out there and I said, I want to do this again for another region. And another region was looking for a leader. And I did it again in another region across 8 medical centers and 5 states this time. And look, my career, I was entrepreneuring all along. And as I got to the level of a builder and a leadership director, it occurred to me that the institution was always going to limit what I could do and what others could do in terms of entrepreneurship, and how the babies that I create as an entrepreneur would be able to grow up. And how can I best take this amazing skill I now have and help the most people? And what I wanted to do was make sure, because what I was seeing is that this was a game changer for people that are disenfranchised, that are rural, that can't get to the hospital, that have many barriers to carrying out healthcare the way we traditionally do it. This was a game changer, a lifesaver, and I wanted to bring it to as many of those people as possible. I didn't feel that I could do that within the institutions that exist in the United States or even in the United States, because our healthcare system is economically based. And when you build things, it tends to go to the same people over and over. And I really wanted to have a different impact. I also wanted to create an institution that would grow more entrepreneurs instead of them having to do it despite the organization. I wanted them to do it because of the organization. So I wanted to create a new and different organization with a global impact, because we can. And it would be a waste for me to take these skills that I have grown and not use it for the greatest impact. Is it terrifying? Is this a big, giant, scary, audacious goal? Yes. But that's great.
Wow. There's so many things that you touched on that I want to ask about and emphasize. But I think the first thing that you said that really hit home was that when you're doing a project, you're working with another organization, or like an organization you work for, know what the stakeholders want. I think that's extremely important. And I think, especially when we're so excited about projects, we can take it in another direction. And that's maybe not what the stakeholders want. So I think that is a very important nugget of wisdom for all of us to take with us, whether even if you own your own business, your stakeholders might be whoever your clients are. Know what they want. It's not necessarily about what we want. It's about what they want. And I think I'm also very excited that you were working through the VA. I think I did a little bit of work through the VA during my fellowship, and I was so impressed with the system, how you could see people's records across multiple hospitals. I think I had some patients, I was working in Illinois, and I could see their records in Hawaii. So I love how the VA manages to keep people's information centralized, even if they're traveling. So to me, that's the beauty of us having some kind of centralized system. Right now, I'm working in Canada, and the province I'm in is Saskatchewan. We can see patients' records across the province, which is quite helpful. Like, we don't necessarily see something like the records that are in an outpatient office, but just having things centralized, it's incredible. If we could do that across the states, wow, that's a game changer.
The VA is, I think, a model for what could be centralized healthcare records. And I'm going to give props to President Obama and Hillary Clinton. This is what they wanted when they were thinking about universal healthcare. But the economic and corporate interests didn't want that. They wanted each to own a piece of the medical pie and the patient's information. But I can tell you, the things you can achieve when that is centralized is a winner for the healthcare system, and it's a winner for the patient. And I really want to stick back to carrying out healthcare in a way that centers the caregiver and the patient.
I think by whether or not some people want that to happen, I think patients are getting a lot more tech savvy. So I think eventually it might, I hope it'll be in our life. I think it'll be in our lifetimes, especially with the way AI and all these things are coming along. I think whether or not we want it, people are taking their screenshot. Like, I have patients who even go to other provinces, are like, here's my account, log in, here's my password, I want you to see this. So I think eventually we will achieve that. And the other thing I think that really was quite intriguing is that you wanted to take what you learned and apply it to something that's more global and will help more people. And I think the other thing that really intrigued me is that you wanted to, correct me if I'm wrong, you said you wanted to have the ability within this new organization you created to create entrepreneurs and intrapreneurs. Explain that a little bit more. Break that down for me a little bit more.
First and foremost, we're creating an organization guided by mission and purpose, not by market. So that's first and foremost. But what I learned, especially in working in a virtual environment, is that Command and control is not the best for growing anything that's special. I think this is a very traditional way of carrying out organization, right? Command, control, and management. Oh, you hear the word management and I cringe and I get a little nauseous. I'm like, who wants to be managed? But everybody wants the highest functioning employee there is. The highest functioning employee doesn't want or need any of those things. So I wanted to build an organization that would bring people in and say, I want to support you holistically as a person. And when I do that, you're going to bring your best energy and talents to the work we're doing. I want to inspire you by what you're doing. If you're not inspired, it's okay. Go build the thing you're inspired about. And I want to give people the experiences that some people are going to stay and some people are going to leave. It's a sign of a good organization and good leadership if your people leave and go do their own thing. They should be growing. They should go out and build their own organizations. So I don't want to own people. I don't even want to own the mission. I want us to build together, and I want us to make the world better. That is the mission.
Oh, wow, that is so beautiful. And I think this is a way, even if people leave, if they know that you're rooting for them, they will come back. Like somehow they will still be attached to what you poured into them. Your legacy still goes on, whether they come back to contribute or not, whether they maybe donate money, your legacy still goes on in another way. So it's like you're making something bigger than yourself and bigger than your vision through the way you're doing things.
And they'll go and build greater and better things than I could have imagined. I'm of a certain generation. They're going to have their own generation and their own views, and they're going to take a little bit of what we built, and hopefully what they're going to take is values and mission and purpose and helping people and go and build other great things. That's wonderful. I want that to be our legacy.
Absolutely, absolutely. And for those who are listening, who are curious and want to learn more, tell us more about what your mission is. Like, what is your mission and what is your vision?
Our vision and our mission is to create access to world-class healthcare anywhere in the globe without concern for your economic situation, whether you're in crisis, and to leverage telehealth to help us do that. Through telehealth, we can share what we have, which is abundance in a concentrated area of the global north, and we can share it and create global abundance, which is going to benefit all of us. Anita, right now, 78% of the world's doctors are only treating 16% of the world's population.
Wow.
In the global north.
Wow.
That leaves 5.6 billion people to be cared for by only 22% of the world's doctors. It creates huge disparities, huge issues of access to care. It fuels things like pandemics, conflict, trust in institutions and governments. We want a better world, a safer world, a happier world. We need to invest in people when they're the most vulnerable. That's a gift that keeps on giving.
Absolutely. So tell us more. Where have you guys begun providing services? Which other countries are you involved in right now?
Okay, so this is startup time, right? Baby startup, we just passed our 3-year anniversary.
Congratulations.
Thank you. But we were fortunate enough to partner with a tech company named VC, with a CEO that has a strong philanthropic desire to build a tech and telehealth platform that's going to work in low resource and low bandwidth areas. Milton Chan was building telehealth for the Philippines. His family comes from the Philippines. Also another new second generation immigrant, right? He was using his platform in areas of the Philippines that are very rural and people don't have access to a lot of health, and building it through clinics. This is the trial and error part of telehealth. He listened to me in one 30-minute meeting and invited me and my team to come along and be a telehealth partner. So hybrid, in-person and telehealth clinics in the Philippines. And we did that over 6 times with VC, where they would have a small number of clinicians on the ground and a larger number of clinicians on telehealth. What a learning experience, right? We can amplify how many patients we can see by having a hybrid environment. We can bring experts in that might not be available on the ground. And we saw that this was a very viable way of bringing more care to people in rural areas. And then I partnered with another organization this year called Global Telehealth Network, who were already envisioning an interconnected network in eastern Uganda and western Kenya, not across the country, but each country having a network of a local regional hospital that can provide support to rural clinics. That doesn't exist currently. You can just transfer your patient from your rural clinic, which often requires you get on a motorcycle called a Buddha and you ride over very bumpy, very not safe roads for at least an hour, sometimes 2 hours to get to a hospital. That's a challenge when you have a broken femur or you're in labor. So connecting them with those rural clinics first. And then secondly, supporting those regional hospitals and the clinics with experts that they might not have in real time. So through telehealth.
That is so amazing. And I was so excited because you started working this project in Uganda, and my family is originally from Uganda. So I was so curious, which towns or cities were you involved in Uganda?
Oh, now you're making it. Now you're challenging me. The first place we did go is to the kingdom of, we were in the kingdom of Buganda, where we were invited to a celebration for the king's birthday, where they were opening a new hospital. And the king and the kingdom are very interested in making sure that they have universal health care for their people and their teams. So again, it was wonderful to meet. We met lots of governors and leaders of healthcare is decentralized. And so the local governor runs the healthcare system. And so meeting those local governors and seeing their desire to be aggressive and forward leaning and making sure their communities can get healthcare. And a lot of them leading initiatives that then become national initiatives when they show success in their region, whether it's getting pregnant women to come for prenatal visits and more deliveries in the hospital, lots of initiatives. So that was really exciting. I have to say, look, the best part of entrepreneurship is you go out and you meet other people and you are enlivened by the fact that lots of people want to do good things. I think when you're behind the scenes as an employee, you tend to have this, everybody's a bad corporate leader kind of idea. There's plenty of those, right? It doesn't take a lot to ruin the trust of people. But when you have the choice to go out and meet the people that aren't like that and to work with them and partner with them, it's really exciting.
Yeah, wow. Yeah, that is super, super exciting. And I didn't know this about the Baganda, that they're trying to have centralized healthcare. That's actually my ethnic group. So this is news for me. I'm sure I'll tell my people, be like, as I mentioned, I'm a very good representative of a Ugandan or a Muganda, but it's very fascinating and very exciting. I can't wait to hear more about the projects you're doing and as things progress. And the interesting thing about Baganda, we traditionally had, I don't know if they told like the traditional healthcare system. It was more like the natural medicine doctors, but I think C-sections were being done in the Baganda kingdom before. I think the British arrived in 1700s. They were doing C-sections before then, and they would use local alcohol to get the women basically drunk, and then the C-section would happen and they'd finish up. And I think another one of my uncles told me, in terms of a pregnancy test, there was a specific frog that they'd use, and women would pee on that frog and the color of the skin would change, and that's how they know you're pregnant. So I think it's very interesting to hear about indigenous means or ways of medicine and how they've been adapted to Western medicine. Like even in Canada, I think one of trees was used to create aspirin. For some reason, the name of the tree escapes me right now, but First Nations people used to use it to manage pain. So I think there's probably so much wisdom in indigenous ways of treating and managing things that perhaps could also benefit Western society.
Absolutely. And I want to be clear about how we're building and rolling out this telehealth support. We're not providing care directly to the patients. We're not bypassing the local healthcare system. We're working behind them and alongside of them. So whatever local healthcare worker is in place locally, they are in charge of the patient, but they have the ability to call and ask for help in real time, not an hour from now, not 5 hours from now. Now, we will have emergency physicians that can help them decide if they just need a routine consult, and we can set that up with a consultant for later. But they're going to have board certified emergency physicians with them 24 hours a day that can help them in a situation to both decide how to help the patient. And you can't do that without a giant healthy dose of humility and openness to learning. because you can't just come along and say, this is the way we do it. This is what you should do. They can't do it that way, nor should they have to do it that way. So we're going to learn a lot, and we're going to gain perspective. And I think that perspective will make us as a global healthcare community stronger and in a better place to actually have an impact on global health.
Oh, absolutely. Absolutely. I can imagine some of my listeners, I think a lot of them are physicians. If they want to get involved, how would they get involved?
Anita's so kind. We do have a website, haew.org, where you can go and you can just use the link that says join us or message us, or you can just email me directly. It's Dr. T, Dr. at haew.org. And that's also a wonderful way to reach out for me. Either way, haew.org is your ticket to getting through to us and finding out more information.
Awesome. So we'll make sure that we put all the links below our show notes so people can contact you and get involved. And I guess probably when people reach out to you, they figure out what their requirements are. Like, I'm assuming, I should not assume, are you recruiting physicians from all over the world, or are you more like focusing on, okay, good.
Yes. So we definitely want physicians from all over the world, right? And this is a wonderful opportunity for people in diaspora communities to help in their community, right? Because they'll have language and cultural competency that an American or a Canadian born and culturally Canadian and American doctor may not have. So we want people from all over the world. We want people that are actually living all over the world as well, because we're going to be working across time zones. This isn't the last place we're going to work. We're going to work in time zones all across the world, and it'll be easier to align the project with your time zone and your language and cultural competency if we have people from all over the world. So you do have to be a licensed trained physician, but all over the world.
Good. I'm thinking some people I can already start recruiting and sending your way, because it's like, even as a physician, it's very hard to describe, but it's like your thought process changes and the knowledge does not, it's very hard to undo what you've learned as a physician. So I think retired physicians would be amazing, because with a wealth of knowledge, this would be fun for them. They're like, yeah, I can advise and share my knowledge. And even if they're not working actively, they could share so much with your staff and also the people on the ground. Incredible.
And trainees, we want the young generation to start this from the beginning. We want medical students and residents to have this global perspective from the beginning.
Yes, you're right. That is so important. And I think the way the world is going, in our training, we should have access to telehealth. Are you partnering with certain universities or any training facilities to have their trainees come and work with you guys?
Not as yet, but I'm here. If they want to reach out to me, I am definitely open to it, because we have the requirements for what it takes, right? We have physicians with the right credentials. We have physicians with academic backgrounds. We have a good number of academic physicians, and we can supervise, right? Because you can have a resident in the same room as you, in a telehealth room, just like we're having this discussion. So we can have direct supervision and we can have education. And it becomes more accessible to more students. When I was a medical student, I couldn't come up with the money and time to go travel to do a global health project, but now it's accessible to everybody, right? You have a family, that's okay. You just need to do it for 2 hours when everybody's asleep. So really accessible. And that, again, this is about equity, right? This is equity for our patients, but equity for our community and bringing more people into the space. And I do think we can do more and better for people with disabilities. And I do plan to push the developers that work with us, because we're tech neutral, right? So we partner with tech companies. We're not building the tech ourselves. We'll push our partners to come up with ways to make this more accessible for people with physical disabilities, visual disabilities, audio disabilities. Why not?
Absolutely. Wow, that is so exciting. I was going to ask a little bit more about what role and technology plays in terms of what you're doing. So in terms of the platforms you're using, are you using something similar to Zoom? And are you using any other technological tools for the physical exam to ensure that the person on the other side can play a role in the physical exam? Tell us a little bit more about the setup and how things are going and what technology you're using.
Sure. We're very proud to partner with VC. So VC is the telehealth platform that's used by NASA astronauts. So the CEO of VC not only is a wonderful PhD, brilliant visionary PhD from Stanford, but he believes in philanthropic work and very early on adopted us, so to speak, to use his platform and help him develop a platform that's good for low resourced areas and also help us build this community and this intervention. So VC is HIPAA compliant. It comes with an EMR. So it's not just Zoom. It also has a simple EMR. Anita, you are a different generation, but I remember written soap notes. It was the wonderful times before the EMR. And that's the EMR they have developed. It's 4 points, soap note, boom. And so it can then integrate if communities have a government EMR, they can integrate with the government EMR and pull that information in. And as to how many gadgets and gizmos you have on the ground, that's going to be customized by each location because that's where you start getting expensive, right? You got to buy gadgets and gizmos, and then you got to have a way to power them, and you got to have a way to store them. And so, yes, we have electronic stethoscopes as part of our early launch so that we can listen. We have a stethoscope that can generate an EKG as part of our launch. We are rolling out some ultrasound. And so those things are going to come. Absolutely. And I invite those people developing those technologies to come and partner with us and help us help you grow your technology so that it can help people all over the world. But yes, there's a lot of technology that can come. So again, we're not building for the high resourced main hospital in the city, though. They're going to get involved as a support for the rural clinic, but we're building really, look, we're talking a rural clinic, right? Where a midwife is delivering patients and her version of suction is a suction bulb. And you're not going to have a lot that you can put in place. But we're going to learn by being there in the room with the people doing the frontline work. And who better to do that than ER doctors, right? We are the MacGyvers. We love to be in a place where you're like, oh, we don't have a chest tube. We're like, okay, give me an 18 gauge needle. I got this. It'll be fun. Over time, we'll bring resources in from learning and from the experiences. And I think that'll be the best part of this. We're, again, baby steps, but on our way.
Absolutely. I love the vision. And I can see how for the next generation of physicians who are learning, like this is invaluable experience. What if the power goes out? Like some of us would not know what to do in terms of writing a soap note. Would be like, what do I do next? And I'm just remembering one of my experience. I think I was in the generation where we were bridging this paper to digital. So as a student, I remember writing some stuff. Then as a resident, we were transitioning. And then as a attending, it was all digital. And I think we had some times where, the power is not working. And I'm like, okay, I'm used to clicking. So one of the older nurses came by me. They're like, first line, admit to diagnosis. Because I'm like, I don't remember. I'm used to like clicking. Like the computer has all that kind of stuff. So they're like, no, you forgot to write admit to your name. You just can't say admit to the floor. So like small things like that. So it's like, these things that seem not as important. It's important to know this information and also to be able to think on your feet. What if your usual stuff is not there? You can still get the information in another way. So I can see the Mets, really learning that you don't always have to have all these bells and whistles. You don't have to have the labs. You can still talk to the patient, like the art of talking to the patient and getting the diagnosis or most of it from what they are saying, I'm afraid might be lost in a couple of
100%. And every time I work in the ER, I'm like, I'm ordering these labs basically to prove to other people what I already know. But I guess I have to do it. Again, this system has been built over time to use so much resources for so few people. And I am inviting our medical community because I know us at a fundamental, deep way that we want to be doctors for all people, not for that 10%, not for that 5%, not for people that have access to the ECMO only, not for people that have access to the LVAD only, for all people. And you can be that doctor in the tertiary healthcare center with all the stuff and still do this on the side and be the doctor for all people. So that's what I'm creating. And I'm inviting people to come along and remember what it is like to just be a doctor and not be a biller, not be a coder, not be a revenue generator and a procedure generator. And to learn some skills about when those things aren't available, how you can still care for people and save lives. You're going to learn. I think as much as we give, we're going to learn.
Absolutely. And I can see this being so fulfilling for people who are working in high-tech resources to have that opportunity to forget writing this 2-page note for the lawyers, for the insurance company, for XYZs, and just be like, okay, this is the medicine. Like I want to get involved in the actual care of the patients. And I think one thing you do touch on is burnout. So how does healthcare burnout impact the ability to deliver equitable care?
I think this is a really big challenge. So I'm going to do it in 2 pieces. So this is how healthcare burnout impacts equitable care here in our North American healthcare systems, and how healthcare burnout impacts equitable care as a global healthcare system and in the global South. So if you can imagine that in the global South, they have a fraction of resources with so many more patients, they're going to be really at high risk for burnout. And indeed, brain drain, where doctors train and they go to some place where they have more economic opportunities and economic opportunities for their family, is a big problem. And which is why all the doctors are in one place. Part of why, not the whole why. Burnout and the epidemic of burnout that's come about since COVID is threatening to have us lose as much as 40% of our doctors within 5 years. And it especially impacts those fields that were the front line during the COVID epidemic. So we're talking about OBGYNs, as well as intensive care doctors, emergency physicians, who had to keep going during COVID. And I don't want to say had to keep going, they would have anyway, but they found ways for the other specialties to go remote. And those people could not, right? So not only did they carry a great part of the healthcare and societal burden for the COVID pandemic, but they carried all the trauma. So they have very good reasons for burnout, and I want to validate their burnout and whatever they need to do to deal with that burnout, because we need to support people. So that is a big threat to what was already going to be a huge shortage of physicians and healthcare workers that was already projected for 2030. And let's see, I had the number written here. Forget how many million, 15 million healthcare workers and 4.5 million physicians predicted for 2030. So that was already predicted before the burnout, and then you're going to add burnout on top of that. Big problem. And again, it's going to impact some people more than others, and some communities more than others. So that is how burnout is part of this story. I do think acknowledging burnout and the reasons behind burnout, which is a lot, is some of it is trauma, right? PTSD, plain old and simple PTSD from what you've seen and experienced. But the lingering effects are also loss of trust and belief in the medical institutions that people are working in and for. And you do not want to give the best of yourself and the best of your broken self if you don't trust and believe the institutions you're working in and for. So this, again, is another opportunity for us to take control. I am always looking for the empowerment and the challenge. That's the story of my life. Where in this challenge can we find empowerment? And I think we need to find ourselves empowered and in the center of the conversation again, and driving the change.
100%. And I think this is part of one of the, as you were alluding to or mentioning, feel like you have autonomy, like you have the ability to make decisions independent of insurance companies, XYZ, because you're the one who is spending time with the patient, you as the clinician. And I also bring our nursing colleagues in and other ancillary staff. We who sit with the patients are the ones who know what the patients want. So we should have our voices heard very loud and clear in terms of what is happening next for the patient, not an insurance company saying that this is reasonable, this is not reasonable. So I think we definitely need to be empowered. And thank you also for talking about some of the challenges we face as physicians and healthcare staff. We see too many things. We see a lot of different things. And I think depending on the institution that you work in or even train in, I remember an attending, I was working as a hospitalist talking to one of my colleagues during the pandemic. And I was talking about, during my training, we didn't really talk much about post-code. Like we'd have debriefings, but we didn't really have any structured ways of coping with all of these things. Our seniors would tell us, just don't cry in public kind of thing. If you want to cry, go in the bathroom kind of thing. And well, my institute, we actually did have debriefing. We actually did have courses to manage stress. So I think I'm hopeful for the next generation that this is more widespread in terms of having debriefing and courses and actual ways to manage the stress. And unfortunately, this is why some of us as physicians, when we're independent, come across as a bit brash or not having good bedside manners. Oftentimes, this is a defense mechanism. A lot of people don't realize that they're not as empathetic, they don't connect, but it's a way, like if you have 25 people to see, you just finished resuscitating somebody died, you don't have time to cry. So at some point in time, you just come through like a robot, and you have to be robotic to function. Otherwise, you can't cry in front of the next person because it's not their burden. You need to take care of them. So it's unfortunate, but I'm hopeful that we as physicians, as we recognize, yes, most of us probably have PTSD. We need to figure out a way to manage that PTSD and manage whatever other stresses so that we can bring our best selves, not just, as you mentioned, our broken selves.
Anita, first I want to thank you for mentioning nurses. I know I say physicians a lot because I'm a physician and I'm talking to a physician. Burnout is affecting nurses at an even higher rate than it is for physicians. And I personally witnessed the hierarchy of medicine at work during COVID, where physicians got access to levels of PPE that nurses didn't. And so if you can imagine the lack of trust and belief in the institutions that exist where you're carrying out health, it's going to be even worse in nursing. And so I do want to acknowledge nurses, and they have it in many ways worse even than physicians. They do have strong lobbies, so that's great. First of all, we can't do the work we do without them, and we need to realize that they are very strongly impacted by burnout. Yeah, I want to hope that we can create ways and some inspiration for doctors that still find a lot of fulfillment and a lot of attachment to carrying out medical care, so that they don't find leaving medicine altogether as their only alternative. I will need to go to a doctor one day in an emergency. You will need to go to a doctor one day in an emergency. Your children, your parents, and who will be there. Really want us to be part of deciding what the end of that sentence is, the answer to that question is. I want us to consider it and then decide how we want to answer that question, because I don't think the answer is whoever's left behind that can hide their burnout, or whoever still cares about money more than patients, or a diluted version of what medical care can be because it's cheaper, or an AI that's going to do it. And you're going to sign away all your ability to even have any recourse to that AI. Every time you update your Apple, you get 15 pages that you didn't read, because who's going to read 15 pages? That's what you're going to get when you show up with your AI hospital. Here's the 15 pages. Sign this if you want medical care in your emergency. Okay, let's go.
Yeah, it's scary. I heard of, I think, fully AI automated hospital in China, but yeah, it's something to think about. And I think your vision is something that gives physicians hope that being a physician still matters. Even if we're in a situation where we're working for a corporation and we might feel devalued, we might not be able to make the decisions we want for our patients, there's still an opportunity to just be a doctor and just have that patient-doctor relationship, even if it is through a different platform, serving patients in a different country. This can help you feel that what you're doing is very meaningful. So thank you so much for taking the time to talk with us. We will make sure we have all the links to your website and to your email address for physicians that want to reach out to you. And I'll make sure that I send physicians your way, because I know there's a lot of physicians who would be extremely excited to get involved and to find breathe new life into their career through working with you.
I would love that. I enjoyed speaking with you so much. You're so thoughtful. You are so incisive in finding the points. It's a joy to speak with you. And thank you, my Canadian audience. Love to meet my Canadian friends. And if folks would like to come on, I also have a podcast where we talk about issues in equity. And if anybody would like to come and talk about what they were doing, I'm always looking for guests as well.
Okay, awesome. I can think of 2 people off the top of my head. I will try and make sure that they reach out to you as well. Thank you again for your time, and we will have you back. And I'm so looking forward to hearing how things progress. I think we definitely should have you back in 1 year. I would love to hear about how things have progressed and moved on. And maybe we could make it an annual thing and keep reminding people that you're still here, you're still going strong, and that they can still join you.
I love that. That's like accountability and a little cheering at the same time. I love it. Thank you.
Yes, we'll look at it as cheering, because accountability, sometimes I don't want to stress you out, but I want to celebrate with you and to see how things are unfolding. So we'll look at it as like a celebration, because this is year 3. So next time we'll be saying, yay, year 4 and then year 5, and just see how things blossom.
Wonderful. Yes. And I can't wait for all the communities we're going to add year after year.
Absolutely. Thank you once again. And again, for our audience, we will make sure that we have all Dr. Tranquada's websites and contact information. And I know a lot of you guys would be so excited to join. So please reach out to her. She is a really lovely physician, lovely lady, and has such a big vision and a big heart for the world. No, not just her community, but the world. And you can also be involved in that. So bye-bye for now.
Thank you, Dr. Lwanga.